Okay, I'm going to go back then so you can see these are the different types of trauma. And then I talked about the viral pneumonia, pleural effusion. Hold on, move that over here. Mesothelioma type of cancer, tuberculosis, pneumothorax, pulmonary embolism, and then the lung cancer. And like I said, all of these can cause a pain. These are the diagnostic tests. And what I was saying was, when you see respiratory therapists go in and draw an arterial blood gas, it is a tiny needle. It's a tiny syringe. They go into the artery and get that sample of blood. It hurts the patient. I've watched it a million times. It hurts to go in that deep to get that arterial blood to check the blood gases and to check your oxygen saturation. That is the most definitive. I mean, a finger probe for the oxygen saturation also gives us the idea with that laser measuring the amount of oxygen in the blood, but this is much more definitive. And then of course we have the radiography, chest x-ray, CT with or without contrast, the ventilation perfusion test or pulmonary angiograms. If your patient goes for one of those, see if you can go with them. Probably not so much for a chest x-ray, but if your patient's going for a CT scan and you're able, go with them so you can see what they go through, unless you've had one yourself. A bronchoscopy is an invasive scope that goes into the lung. That is super, that you hear a bunch of secretions and a bunch of coughing. It's kind of rough. A thoracentesis, where they go right into the lung and pull fluid off, and then the pulmonary functions test. Those are all done in the specials lab. And I hope that you can witness them if you can, because if your patients are going for a test, I really think participating in that is really a big help. For a pneumothorax, air in the pleural space that can cause the lung to collapse, and it may be accompanied by a hemothorax. I know this is part of your a test question for your free response, because you're going to be asked a lot of questions about chest tubes. That's your free response question for this test. And if you look at my little picture here, you see a closed pneumothorax is where there's air in the lung and it's collapsing the lung. It's air in the pleural space. An open one, there may be a trauma to it and air is rushing into the lung. And then a tension pneumothorax could be both. So you're looking air in the pleural space, increasing and unable to escape. So it's going in, but it's not coming out. And you can see on the right side, the lung is fully capable of inhalation, but on the left side, you're seeing that lung is collapsed. It's not to capacity, and you're not able, the lung is not able to expand like it's supposed to. There are ways to fix that. Signs and symptoms, anxiety. Some people get spontaneous pneumothoraxes. We had a peds patient, he was 16, who would just be doing nothing, playing video games, and have a pneumothorax. He would have them spontaneous all the time. And I don't know exactly what the end game was for him, but he was in the hospital probably for the first couple of years that when I started doing clinicals on peds, and he was in the hospital a lot. So nobody knows why this happened to him. Anxiety, you start having a rapid or labored breathing, or it's absent, like diminished breath sounds on the affected side. There's a tracheal deviation from the midline. So you'll see where the trach is of the patient, and it's, pulled off to the side, a very weak pulse. Rapid hypotension, so that comes on quickly, like your pressure goes way down. Heart tones are muffled, and then the distended neck veins. So subcutaneous emphysema is a super weird thing to feel when a patient has a pneumothorax, and you feel here like crunchy, a really crunchy, weird, like Rice Krispie sound. I'm going to see if this works. Let me just check. I'm going to try it. May not. I want to show you this one if I can.
Linda, sorry to bug you. I have a question about Hello, Linda?
The
Can you guys hear
pathophysiology is
that?
as follows. Air gets trapped in the pleural space.
Yes.
Moves in during inspiration, but it cannot leave during expiration. This accumulation then leads to shifting of the mediastinal structures, compressing the heart and lungs and impairing function and oxygenation. The decreased venous return and hypoxemia then leads to decreased cardiac output and eventually cardiac arrest. Signs and symptoms of pneumothorax include respiratory distress, as seen in nasal flaring, cyanosis, use of accessory muscles, tachypnea and dyspnea, unilateral movement of the chest and tracheal shift, surgical emphysema. This can be felt as a bubble wrap popping under the skin
That is
and is
really
best
weird.
felt in the region of the clavicle. And chest pain, usually an abrupt, sharp and constant pain, may also be present. Signs of decreased venous return, such as jugular distension, may also be seen with pneumothorax. And signs of decreased cardiac output, including mental confusion, angina, oliguria, hypotension and tachycardia, and decreased pedal pulses. On auscultation, absent or hyper-resonant lung sounds on the affected side might be noted. Chest X-rays may show a deep sulcus sign, mediastinal shift, tracheal deviation, translucent appearance of air, and the absence of vascular markings.
That was a nice short one. The subcutaneous emphysema, like she said, postoperatively, a patient last semester had a picture of herself. She showed us when we walked into the room, the patient showed the student and I this picture of herself because she was so disfigured from the air that she had accumulated during the surgical procedure, and just touching her here sounded like cellophane just crunching like definite Rice Krispies. It was so weird. And she goes, I don't look like this. I mean, she was so swollen, like twice the size of her face. And she was a very attractive woman and she was so wrecked. She goes, this is me. This is really me right here. I don't look like this. How long is this going to take? And, the nurses reassured the patient that the subcutaneous tissue, that the air there would dissipate and it would, go back to her normal, the way she looked. But she was very freaked out about that. And it is something to see for sure. And when you feel it, when you're listening to it with your stethoscope, it's definitely something to share. And some of the students were, the patient said, sure, her classmate can come and listen. Something definitely that you definitely want to experience so you know what we're talking about here. This flail chest is another one, common complication of a trauma. 3 or more consecutive rib fractures, which I think you can see it, but it just goes in and out, in and out. That's a definite flail chest because the fracture of the ribs is not supporting. That is that's a pretty scary one. Chest tubes. So we are going to talk about our chest tubes. It is going to be part of this is part of our section, even though it's not part of our skills. We were doing it in our skills and going through all of it in the skills lab, but semester 4 took that to their content, like I said. The purpose of the chest tube is to re-expand the lung, reestablish the negative pressure, to facilitate the lung expansion and normal breathing. Many of you, let's see, I'm going to see, ask for hands. I don't know why our Zoom thing is acting so weird today. How many of you have had chest tubes with your patients? I just see like a couple, 2 or 3. That's weird. Well, it's third semester and it's the beginning, but you'll definitely have patients with chest tubes. And chest tubes are so useful, so great, and something to definitely be respected and cared for, because we had the incident where a person delivering the meal tray walked in. There was blankets flopping on the side of the bed. His foot got stuck and 2 chest tubes got pulled right out of that patient when he turned around and walked. And he almost fell in the room. It was horrible. The old gentleman that got the chest tubes pulled out was like, oh. screaming, and it was traumatizing for the patient. It was almost more traumatizing for the gentleman that was bringing the tray in. He was a very experienced part of our hospital, such a great guy. He was devastated. The residents were on the floor because it was morning breakfast tray, and they were able to go in, immediately reinsert chest tubes, set up, they went in, and within like 20 minutes, the chest tubes were back in this gentleman. He was in terrible pain. The student had to help with meds. The nurse and the nursing student were in there assisting. There was like 4 surgical residents in there. They got them back in. And the reason I'm telling you this is because had that bed been tidy, that room been tidy, the blanket on the bed to where you could see the tubing, you could see the chest tube, that never would have happened. You could visually see the room was such a mess. And you guys go into patients' rooms all the time in the morning. It looks like they were having a wrestling match in there at night. Blankets thrown everywhere. Everything's a wreck. People keep waking up these patients. They're a mess. Tidy rooms are so important, not just because I have such a fixation with it, but because it keeps things in order. Less mistakes happen. I'm telling you, it's just a rule of thumb. Get in there and see what you have, but definitely when you have a chest tube, and the chest tubes that are on my slides are the older version. Now, if any of you work in the hospital, in the SICU and the MICU and the ER, or on surgical trauma, if you can get a hold of a chest tube, the new canister, can you please ask if you can have it? If it's not been used, obviously, sometimes they get open and they actually, once they're open, they can't be used on a patient. We haven't had that yet. And there's a new canister that's much smaller and more compact, and I'm going to show it to you. I'm not going to show you this, but we re-expand the lung with the chest tube. We reestablish the negative pressure to facilitate lung expansion, which all of us are expanding our lungs at the moment. So you do need a consent prep system before insertion. So that means it's kind of like you're priming the system with the proper air. You have the patient sit upright. They sit over their bedside table if they can. That's ideal. And then administer the sedation or the pain meds. That's something that we can do. And then the healthcare provider, we assist them. Even as a student, you can call your instructor in, you can call your primary nurse in, you can be there to assist. I've assisted to where I was just holding the patient's hands like this and talking to them. Applying the dressing and then maintaining the respiratory status is what the function of it, but that's our responsibility, and you can certainly be in when they're doing it. They may not need your help, but you can be there observing and you could be part of that team. This is what our old chest tubes look like, and we have these in the lab, and it shows you the air leak monitor, suction monitor. You can see the suction control regulator, positive pressure, the port, the manual high negativity vent, the chest drain connector, and then you look down here, the collection chamber. Collection chamber is something we'll talk about right now because you'll be part of that. So here it says to help remove air from the pleural space, but not to exceed negative cm suction to the wall. I mean, they are to wall suction. They are making noises. Let's say you go in for a report. Here, over here, where you see the function of this chest tube in each part, here is the collection chamber. It's pulling fluid or not. It's pulling fluid like a serosanguinous. Sometimes it's pretty frank blood that you're seeing in this chamber. And after each shift, you get the black Sharpie. And let's say there were 500 cc's, you line it up right here and the time. So at that point, you're going to see how much fluid has been pulled off that lung. And then in another 6 hours or 12 hours, you're going to see again, and maybe there's no more fluid. It says 6 a.m. here, 0600, the date, and then maybe there's 20 more cc's or nothing. If that's the case, at that point, the physician will clamp the tubing. See how the patient does respiratory wise, do another chest x-ray. If the lung is healing and getting back to its negative pressure, the chest tube can be pulled. They'll clamp it maybe for the shift. they'll clamp it for 12 hours, but ideal is to get the tube out and get the lung working back to its normal capacity. And that's the objective of the chest tube. We have these in the lab, so you can take a look at them. And this one, oh yeah, this, it says allow air fluid to escape, but not to enter. They do have the Heimlich valve, so patients can go home with their chest tubes, but that's a little more than what we're going to look at. The complications is what we are going to look at, because this happens every single semester when these questions get asked. So remember this important word of advice. If you go into a patient's room and you're going in first thing in the morning, you're getting your report, you're hearing that, you know, there's continuous bubbling in the water chamber and there is an air leak, and that's what they want. They're listening to it. That's the baseline for this patient. That isn't something that you're going to stop, pull, disconnect. You want to make sure all your connections are secured. You're looking at your patient, and that's the normal baseline for this patient. If there's a loss of suction, no bubbling in the suction chamber, all of a sudden, ensure that your tubing is all connected. And then you want to make sure that this is where your baseline is for your patient. So you are always going to have your primary nurse to fall back on with this, because you are going to be anticipating complications. So here it says, one of the complications, tube chamber disconnection, immediately place that tube in sterile water. At the bedside when there's chest tube, there's gigantic hemostats. They look like huge hemostats, and a bottle of the sterile water that you would put the tube in if it did get disconnected. And then there'll be the 3-sided petroleum jelly gauze tapes that you would cover it with. The 3-sided is important to remember, because you don't want to completely cover it and occlude that spot. So it's always going to be the 3-sided tape, important to remember. And then you're assessing for subcutaneous emphysema, because if there's an air leak that's coming from the lung, not into the chest tube and getting into the actual tissue of the patient, then there's a problem. And you'll hear that Rice Krispie problem. It happens in lung surgeries often. It's something that is regulated or assessed, and the patient gets talked through it, walked through it, so that they know that this air does dissipate. One thing I know, when this patient was disconnected from the chest tubes that we had, one of the older seasoned nurse said, I know you don't need to sit in a shower. You know, you've had lung surgery, but go in, sit in your shower. And you know, those bathrooms at the hospital, those showers are so lame. They flood the whole room if you don't put towels down or whatever, bath blankets, but whatever, that's for another day. The nurse told the patient to sit in the shower with the steaming hot water, not necessarily on them. It was on her feet. She said it felt good, because she didn't want to submerge her chest or anything in the water. And the steam from that hot shower helped to dissipate some of that crackly emphysemic air that was stuck in the tissue. That's just something that it worked. If a chest tube does get yanked out, it goes right into the sterile water and may get reconnected if it's not been contaminated. Obviously, if it was on the floor, they're going to do a whole nother system, but these kind of things do happen. Patients move around, or patients get over it. If you're looking at this as just a normal lung picture, if you see a little tiny lung space and air or fluid on x-ray, there'll be either a pneumothorax or a hemothorax. Pneumothorax is air in the lung. Hemothorax is blood in the lung. And here, restrictive lung disorders for a pleural effusion, accumulation of fluid about the lung. So dyspnea and movement of the chest wall, they can't move in and out because there's no space. So the pleural space has transudative, exudative, or an empyema. An empyema is one to definitely remember. Does anybody know what an empyema is in the lung?
Pus.
Pus, yes. So pus in the lung. Okay, there can be different ways. In addition to the chest tube, they might put a Penrose drain in the lung, and this nasty secretion comes out. And for some reason, that pus in the lung smells so bad that once you smelt it, you never forget what that smells like. It's awful. And a lot of times the residents will MacGyver something with the assistance of a pulmonologist to pull that fluid off the lung and to continue with the chest tube. The empyema, sometimes, obviously, they're on a very strong antibiotic. Sometimes they'll be taken into the specialist lab and get this pus pocket washed out. Very painful for the patient. They'll wash it out and they'll put like a talcum powder in it so that more fluid or pus doesn't accumulate. It's a very strange situation. But remember that it's painful. They feel very bad. Like, it's already hard enough to have a chest tube in. They hurt. Any assault on your lungs is painful because you're constantly breathing. All of you are constantly breathing, right? You have to feel this pain every minute. But an empyema makes you feel sick. Pus in your lung makes you feel maybe nauseous. It's painful, and you're running a constant temp because your body's trying to fight like whatever this is. So keep that in mind when you think of the empyema. Pleurisy is the inflammation of the pleural sac, and it's painful, very painful. The problem with the pain in this area is pain medicine. What does it do? It decreases your respirations. So you have to find a fine line of how to keep the patient with the pleurisy, not out of pain, but you want to manage the pain. It's abrupt, it's a sharp pain. Pleuritic pain is sometimes, they feel like they're having a heart attack. Shallow breathing, they want to avoid any necessary movement, but in order to exercise the lung, you need to breathe. So there's the fine line. It could be pneumonia, a neoplasm, chest trauma, or an autoimmune disease that's causing this pleuritic pain. I know that post-pneumonia patients get pleurisy and they get medication for it, oftentimes an anti-inflammatory or a pain medication. But at the same time, remember too, it does decrease your respiration. So with that being said, you have to find the happy medium. That is a hard one to manage. Restrictive lung disorders for the thoracentesis is when you go in and aspirate. They do a lot of thoracentesis right at the bedside. And that's something that you can assist with, meaning they're going in and that fluid looks kind of yellowish that they're pulling off the lung. A lot of patients with long-term illnesses, advanced carcinomas, a lot of patients that have lung disease will go in, and I kind of feel like they save up until they can't stand it anymore, and they go in and they get that thoracentesis where they go in, get the fluid pulled off, and for a short time before that fluid accumulates again, they get a break, they get a breather, they can have some, lung rest. So position the patient on the side of the bed, they lean over that table like this, like when you're doing a chest tube insertion. Healthcare provider inserts a needle. It's better that the patient doesn't see the needle because it's about, 5-6 inches long. It's long. And it goes into the intercostal space. It pulls out that fluid, but it's something that you as the student or as a primary nurse can go in and assist with. And they welcome that. We don't want patients' families in there. Just seeing the needle, some patients' families have fainted. And you don't want to have any extra trauma or anybody else to have to take care of in that room. So you say we're doing a procedure, it's a sterile procedure, we're going to have everybody step out. The only thing I can say that was good about this horrible pandemic was there was no visitors anywhere. Even for patients that didn't have COVID, there were no visitors, so you didn't have to worry about that extra step of trying to get people out or, that kind of thing. But this is one of those sterile procedures that you can assist with, but you don't want an audience there. You can support the patient if you say, I'm sorry, the family members have to be out now. You can talk them through it, hold their hand, whatever they need. It's the insertion needle is connected to tubing that's connected to actual bottles, liter bottles. And I've seen 3 liters taken off a patient, 3.5 liters. That's a lot of fluid off a lung. So imagine the patient who's having so much distress breathing, and now the elephant just got off their chest. It is such a relief for these patients. The underlying treatment, it says you still need to treat that, of course, but for a respite, for a time, this patient has a little bit of assurance that they can breathe in and out with having so much stress and strain. And it's something that you definitely want to be able to witness if you can. This is just a grid of how many different types of lung diseases there are. And it's, this, excuse me, it will show you the different types of lung diseases that there are. And then it goes down to the idiopathic and idiopathic pulmonary fibrosis, different types of diseases and what the prognoses are. It's just something to keep in mind. Idiopathic pulmonary fibrosis, signs and symptoms, exertional dyspnea, and that goes with a lot of the pulmonary disorders. Exertional dyspnea, where you do one little thing, even the COPDs or CHFs, you get up and you can't breathe. But it's chronic, dry coughs, inspirational crackles, and you'll see in their hands, because of the decreased oxygenation, clubbing that almost looks like an arthritic hand. The clubbing came from this pulmonary condition, not from actually arthritis, but that's what they look like. Open biopsy with the VATS, or the video assisted surgical procedures, and the CT scans, and you'll see a lot of patients post-operatively on 3RT, if that's your floor, that have had the VATS done, and they're in there resting their lung. Perhaps they have a chest tube in, or they're on, high amounts of oxygen, steroids, and then, different treatments for the symptoms that they're having. It says it's got a poor prognosis. 5-year survival rate is 30 to 50%. And idiopathic pulmonary fibrosis, you will see on 3-wood Clysons a lot. Pulmonary edema, you've got your embolisms. So for the pulmonary edema, a lot of the treatments would be medications and then respiratory treatments. For an embolism that's blocking, they may have to get on a heparin drip. They have to have surgical procedures. There's a lot of different things that are done. Preventing pulmonary embolisms, or, that moving a clot, what do we use in clinical for our patients when they're on the surgical or medical floors? Anybody? You do 2 things, really. Nobody knows? Come on. Yeah, you do. You check their legs every time, and you see you have to put your pneumatic stockings on them, or you're going to be giving your Lovenox or your heparin injections. These are things that will aid in, so that these embolisms don't occur. Dyspnea, hemoptysis, and chest pain are the classic triad for the embolism, and they can come on quick. There's something that we don't just overlook. Anxiety, sudden onset of unexplained, like shortness of breath and tachypnea, tachycardia. You're going to want to act quickly on that. Not, well, I'll be back after my break and we'll talk about it. No, you want to act quickly, because it could be a sudden collapse, like a severe embolism, sudden collapse, pallor, they get very pale, they severe dyspnea, hypoxemia, and then a crushing pain. And it can go fast, but it can also be treated quickly too. Pulmonary embolism treatment, administer O2, and then they start the IV drip. They're definitely giving the oxygen so that the patient can still perfuse, but diagnostic tests, ventilation, perfusion scan, a D-dimer test. And these patients would immediately go to the unit, get on a heparin drip, and have, mechanical ventilation right there if it's needed. and they are on bed rest for sure. They don't want that clot to move. They want to dissolve the clot. But what can happen too is if they get over heparinized, they can also have bleeds. So it's a really delicate, a pulmonary embolism is a really delicate condition, but the treatment is also fast and furious and a lot of times with good outcomes. Pulmonary hypertension is a scary one for sure. Elevated mean arterial pressure greater than or equal to 25 at rest, assessed by a right heart catheterization. They go to specials lab. Okay. All right, you guys, please take 10. We'll come back to this. There's not much more, but we will come back to it. It's categorized into 5 groups. So the 5 groups: pulmonary arterial hypertension, the pulmonary hypertension due to left-sided heart disease, that's the most common, and then pulmonary hypertension due to lung disease and or hypoxemia, the pulmonary hypertension due to chronic thromboembolism, and then an unclear multifactorial mechanism. So that's the one that nobody knows why it happened. I do remember probably about 25, 30 years ago, there was a medication that women were taking, and it was FDA approved and then quickly pulled off the market, that was causing pulmonary hypertension. Men and women were taking this for weight loss. It was a diet called Phentermin and Fen. I can't remember exactly what the name of these meds were, but people were showing up in the emergency room, you know, short of breath, unable to, and dying from pulmonary hypertension. So that was a super scary thing. Did somebody say? That was a super scary thing to have this hypertension happen drug induced. And like I said, there's the different types that happen. Idiopathic, inherited drug, and toxin induced. That was that one. Connective tissue diseases, HIV, and help me, Bear, how do you say that?
Well, I know how I say it, but I don't know if it's the right way. I would say schistosomiasis.
Stomatiasis. I don't know. That's a hard one. That one is a very hard one to say. But just examples of where this pulmonary hypertension comes from. It is severe, progressive, rare, or fatal. Those are the categorizations from the World Health Organization. So thinking of that, and over here it says group 3 due to lung disease and or hypoxemia, lung disease caused by cigarette smoking. I have to say this a lot. Cigarette smoking is kind of getting extinct in this world. I mean, in California anyway. Like if you go around and you see, back in the day when I started at Cottage Hospital, nurses and doctors were smoking at the nursing stations. What? That is so unheard of. They'd be sitting there charting, smoking in the birth center, in all the waiting rooms. There were those long, tall, standing ashtrays. People smoked everywhere. If you saw someone smoking in the hospital right now, you would just freak out. I had a patient some years back that was smoking in his room. I walk in, whoa, what are you doing? Oh, nothing. I said, were you smoking? No, smoke coming. It's like, you can't smoke, man, you're on oxygen. Give me the cigarettes. And he was just like, okay, you got me. Really? Because the whole room smells like smoke. I mean, it's just something that, anyway, that's the smoking thing. But yes, it is, lung disease can cause a pulmonary hypertension. That is a pretty serious one. And embolism signs and symptoms, I do want to watch her, because then we're just down to just what the management is. Oops. And she's really, this happened here, sorry. And we're almost done anyway. So. Can you hear?
I guess it all started in 2012, when I was pregnant with my 3rd child. My leg got swollen, and so I went to the hospital and they told me it was a blood clot. And then the blood clot traveled to my heart and my lungs. I'll say it got like a really, really bad 2 years ago. and that's when they diagnosed me with PH.
So pulmonary hypertension is a condition where the blood pressure in the lungs is higher than normal. The blood flow through the lungs is less, and because of that, they're less able to put oxygen from the lungs into the blood. So patients have symptoms of shortness of breath, heart failure, etc.
It got really bad when I went to the hospital. I think it was last year in September, and I collapsed when I got to the hospital, and they transferred me to South Miami. And that's when the Dr. Blank, told me about the possibility of having open heart surgery. So I came here to Orlando, to Florida Hospital.
When I first heard about Karen from the physicians in Miami who transferred her up here, my initial thought is this is one very sick young lady. She had had initial blood clots in her lungs many years earlier, and she had had several recurrent blood clots, each time failing therapy. And so I think it's really a great thing that her physicians recognized what was going on and found the right place to get her to.
The team was awesome. I just remember going into the surgery room and just feeling safe and, like very peaceful in a way.
Karen had a specialized procedure called a pulmonary thromboendarterectomy. In that type of surgery, the operation is to actually go into the blood vessels in her lungs and dissect out that chronic hard blood clot that's built up over years. It's an exceptionally specialized surgery. Very few people in the country do that. We're really fortunate to have Dr. Dwayne Davis here, who's probably one of the most experienced surgeons in the world when it comes to this procedure. In people with this particular type of pulmonary hypertension, this surgery, the PTE, or pulmonary thromboendarterectomy, is a curative therapy.
It went great. I woke up and all I remember is actually feeling that I could actually breathe, finally.
I'm personally really gratified that Karen got to us. I think the team that we've got here is amazing, and I think the collaborative effort between the physicians in Miami and the physicians here and the entire team that we have here truly saved Karen's life.
Sometimes when I look at myself in the mirror, I see my scar and I see someone that was strong enough to go through it. And it reminds me of the things that we can overcome.
Pretty interesting, huh, guys? And any thoughts?
I guess
on
it all
her?
started when in
Oh, no, we don't wanna
2012
see you again,
when I
and
was
we like
pregnant
you
with my
coming
third
back.
child.
I mean, imagine if she had a condition, a pulmonary condition that's exacerbated by this pregnancy, and to be able to be in a hospital where that particular surgeon, who's world renowned, can go in and do that type of surgery. I had never heard of that. I mean, we do carotid endarterectomies all the time in our hospital and all over, where they go in and they take a clot out of your carotid artery. But to go into the actual lung and do that, that is pretty specialized, and it saved her life. And she's a cute girl. Happy for her that she was able to have that surgery. The signs and symptoms, again, blue tint to the lips or to the skin when you're blanching the fingers, shortness of breath during normal activity, wheezing, hypoxemia, tiredness, dizziness, or fainting, swelling of the abdomen. She said it was swelling of her legs and her ankles. So again, it's hard because these kind of symptoms can show up for other things like what? Let's say the swelling of the ankles could be, a different condition. You could have an endocrine condition. You could have, a thyroid condition, hyperthyroidism. Some of these different conditions show up with the same symptoms, but, getting it right is the main thing. And it's scary because I see with all the different pathophys that we talk about all semester, how so many of the symptoms cross over. And some of them could just be us day to day, like, oh gosh, now I've got this, for sure I've got this, and it is kind of a scary thing. For the embolism, they're going to give oxygen, calcium channel blockers, anticoagulants, the fluid correct the fluid and electrolyte balance, so acid base imbalance and dehydration. The bronchodilators to open up those lungs, and then monitor the PTT and the INR to see if their clotting factor is there and okay. Enforcing the bed rest is a hard one, definitely for patients. They're like, I've been laying here for 3 days, and it's like, no, they take them back, scan them and say, no, these blood tests are done every day to see if the condition is normalizing. So I just feel like when you get those patients and especially on 3 Wood license, we get a lot of lung condition, surgeries and traumas on 3RT, but the chronic and idiopathic conditions go to pulmonary renal. And they're very equipped there to take care of these patients. But for our sake, we're going to go through, don't forget to watch your videos. For our purpose, we'll go through and we'll see what kind of conditions we're going to be taking care of. Hold on. Why am I having a hard time with this? Let's see. Okay, there we go. You can still see me here. I would like to go to our chest tube unit, which is spelled out very clearly for you guys. It's a really good one, our resource. I want to go over that with you. And there's a few others that you can look at, but this one is the one that I want you to definitely, hold on. I'm sorry, it's kind of small on the screen, but you guys have it. So you want to know these 25 things, and maybe 5 of these things are going to be asked in your free response. But most definitely, what are the chest tubes used for? We want to get that lung back to normal expansion and working condition. Where is it placed specifically? And it'll tell you as we go through, where is it, what are they used for? How long they are, where they go, which intercostal space they get put into. What's the difference between a pneumothorax and a hemothorax? If it's a pneumothorax, we're talking about air in the lung, which is collapsing this lung. If it's blood in the lung, you'll see a different color on the chest x-rays. How do the 3 chambers work in the system? And when you're in the lab, take a walk over and take a look at it. This is the prehistoric type, but it kind of gives you a visual of what these exact top chambers do and how the system works. The one that they use in the hospital now is like the size of a half gallon of ice cream in the square box. That's about how easy it is for them. And they do get to take them home. A lot of patients go home with a chest tube in. They're really much more convenient to get their lung expansion back to where it needs to be. And it tells you all the different uses. For our purpose, we never milk the tubing, but for our purpose as nursing students and even as primary nurses, bringing the patient back to homeostatic pressure is where we want to go. But to make sure that you're monitoring where this patient is specifically, meaning some of them won't have any bubbling in their chamber. Some of them will have it flat, quiet, no secretions coming out. They clamp the tubing and see if any secretions then accumulate, and they'll pull it. Sometimes the chest tubes have to go back in, and that's heartbreaking for the patients because it's painful, it does hurt, and they feel often a setback from it, which of course is understandable. So a setback from, a lung that's healing, and maybe they have to go in, and maybe it's just a temporary setback, and then, the lung expansion happens and they can pull it again. It says the regulated wall suction is applied, partly filled. Sometimes it is to low continuous suction. And it says here, no matter how hard the wall suction pulls, the actual suction delivered to the patient is only as hard as the amount required to pull out air past the fixed weight of the water. So that's a mouthful, but it's only going to pull out what is necessary. Like if it's going to be fluid or if it's going to be air, that low continuous suction. And that's what the chest tube and the chambers are working for. Super confusing, but I'm going back to you filling this out. That was a lab skill. We'd have to go over it in lab, and you'd have all these questions filled out. Fill them out so that you know what they're for. Fill them out so we can see if the chest tube port is in the chest. If it gets pulled out, what would you do? If it got pulled out immediately, you put it in the sterile water, you call your primary nurse, you'd call the surgical resident or the pulmonologist. They'll come, they'll reinsert it or not. The one poor old guy that got them both yanked out, right and left. That was just an awful day on 3RT. That was an awful thing that happened to that gentleman. He was really hurt badly, and it was, well, it was just a bad day for everybody. But going through all these questions, that's a good worksheet for you. And all the answers are right here. It takes 2 seconds. If you print it and highlight it, you can go through and know exactly. It's not a real difficult exercise. I want to show you one other thing before you take a little break and go. I think this is the same one. Yeah, it's the same one. Sorry for that. I thought I had a little video on it. No, this is just a respiratory videos for the lecture. Chest X-ray interpretation is not anything. I just like you to see what it looks like, because honestly, unless you're an X-ray tech or a radiologist, can you even understand what a chest X-ray, what you're looking at? It's white, it's gray, it's a mess. But when you see a collapsed lung, you can see the area of white is pushed up, or it's a lot more. If there's fluid in the lung, you can see like a grayish area as opposed to the lung that is normal. That's just really basically what we talk about there. But for the chest tubes, when we're in the lab, not this Friday, but next Friday, we'll look at the chambers, and you can kind of go through. There's little pamphlets there that we have in the lab, unless she threw those away. And it kind of just walks you through it. Again, if anybody has an opportunity to get us a chest tube, you'll get extra credit. To get us the new chamber, you'll get extra credit if we can snag one. Don't go and snag one from the hospital, though, if you work there. That's not cool. Don't do that. But we have alerted everybody that we want one, because I've told Sharon, and they are kind of expensive just to buy for a demonstration, but we are working on maybe having the company give us one, just so that we can, educate people on the new type of machine that's used. That doesn't mean that if a patient comes into the hospital that maybe is transferred from another facility, that they don't have these chest tubes. And I have still seen them in the hospital, the old style, but this old style has the same mechanism. It's just super condensed. It's super clean cut. It's a really good new, oh, they're already in Playa del Carmen. I'm so jealous. My friend just got to the beach. It's a new, different mechanism that's much more clean cut, not as bulky, and hopefully not one that can hang on the bed that you can see very visual. It hangs below. A point to take is, if you have a patient with a chest tube, make sure that room is tidy. Make sure those blankets are all over it, and that you have a visualization of the tube. There's no tubing lying on the floor, because that's when accidents do happen. You want to definitely respect that process, because patients get hurt very badly. Now, the best case scenario is you go in and the chest tube's been clamped for 12 hours overnight. There's no respiratory distress. The patient is feeling okay. They're saying, yeah, it hurts at the site when I breathe, but no, I don't have the pain that I had before. Residents come in, usually 6 to 7, run in there and watch this great big long tubing that gets pulled out, and then that dressing, that 3-sided dressing gets put on those patients, and they, heal from there. They take it slow. They're not running marathons. If they get up and they can walk around a little bit, it's kind of like a progressive thing that they build on. And that is a really good thing for students to work on as part of one of on their concept maps of problems that you worked with, was getting the patient back to mobility, or getting the patient building on their mobility. Because at first, maybe just sitting up at the bedside was hard. And you're like, well, I just walked them all around the unit, but they had the chest tube there working for them. It's been pulled now, and let's see how they do without it. And that really is the objective. You want to make sure that you get them back to where they were, or even to a better state, and build on that, and reassure them that once they've had pain medicine and that window of efficacy is there, that the medicine's working, then they can go take their walk right at the height of the efficacy of that pain medication, and that they can take their respite after that. So a nice walk after their pain medicine is kicked in, and then a rest, and then do it again. So that's how you would build on somebody that is post chest tube. And, you know, hopefully you send them home and they don't get one. People with reoccurring pneumothoraxes kind of have a lot of, I don't want to say psych issues, but psychologically they're just spent. They're tired, they're drained. They need a lot of encouragement because, you know, let's say it's been 3 months, they've been doing fine. They started going to the gym again, then all of a sudden, boom, a collapsed lung again. So there's that. And they don't have any other lung conditions, but these spontaneous pneumothoraxes. People with long-term compromisation, they're compromised, however you say that, they are also, you know, just waiting for the next shoe to drop. They're waiting and they get, you know, respites in between, but they do have lung conditions. Patients with these lung conditions definitely suffer from chronic pneumothorax. Hemothorax is hard too because it's blood. And when you're losing blood, you're also having other signs and symptoms, meaning that you're feeling anemic, your hemoglobin and hematocrit are dropping. And it's not just shortness of breath that you're struggling with, but the other organs are not getting that profusion that they need. So the chest tube that I helped put in was 3,000 out of blood the instant that chest tube went in. It was like that chamber filled up, and it was so scary for the patient because he goes, "You just here helping me and you let that guy stab me?" And I was like, "No, he put the tube in." He's like, "He just stabbed me and you just watched. Like, well, I thought you were here to help me." And I'm like, "Oh my goodness." No, the chest tube went in, it's going to stay in. You're going to start feeling better and stronger. And the guy swears that the resident just came in and stabbed him just like that. So thinking of that, keeping that in mind, you will take care of these patients. I hope that when we do go into lab, you take a look at it and we can go over it again. If you bring your papers with you, that one sheet, any questions we can answer there, we can try to do that. It's definitely a worksheet that if I were you, I would do. Those 25 questions are right. The answers are right below. Fill them in so you can get pen to brain and that you wrote it down so that you can remember it. Remember, an empyema is that pocket full of pus. That makes them feel even worse. Fluid and pus in the chest wall makes you feel sick to your stomach a lot. Those patients really feel bad, even worse than somebody that's just got a hemothorax or a pneumothorax. So that's one to remember. Remember, heme is blood, pneumo is air. Don't forget those two things. Which intercostal space, 4th or 5th, you're going to get that chest tube in there for that relief and getting that lung back to its regular pressure. Gosh, I think I've told you all of them. I'm not sure. Maybe something else you might want to think about. But it's 10:20. Your quiz opens at 11. I hope you go get something to eat. Remember, growth and development. There is not a free response question on that. Erickson's growth and development, that kind of stuff. I think there might be a lice question in there or something, or a scabies. I can't remember, but maybe not scabies. Think about those things. Go take your test at 11, and then after 11, we'll meet for a very quick lecture and you'll be done. See you guys.
Thanks, Linda.